So we're now going to move on to our panel discussion. So we're going to have more time to hear from Nav Lewis, but we're also being joined by Professor Andron and Jenny Shaw from NCISH. So if we can get everybody up on the screen and we can do some introductions, I can see you all appearing. Excellent. Anne, would you like to just introduce yourself briefly so people know who you are?
Hi, I'm a professor of public health and psychiatry based at Swansea University, but I chair our National Advisory Group on Suicide and Self-Harm Prevention and co-chair the Welsh Government board that oversees the implementation of our strategy. And I'm also a trustee of the Samaritan. And my research very much focuses around suicide and self-harm prevention and children and young people. And I've got a background in primary care and public health, so I come at it from that approach.
Fabulous, thank you. It's great that you can join us today. And Jenny.
Good morning, everyone. So I'm Professor of Forensic Psychiatry at the University of Manchester and an honorary forensic consultant psychiatrist at Greater Manchester Mental Health. I'm also a panel member on the Independent Advisory Board on Deaths in Custody. And my research interests have been in mental health services in the criminal justice system and also suicide and self-harm within the criminal justice system. And currently for NCISH, I'm leading a new study which is just about to start, which is looking at suicide in people in contact with drug and alcohol services.
Fabulous, thank you. Really glad that you're with us today as well. So everybody watching got the memo. There's been a huge amount of questions and we're definitely not going to be able to get through them all today, but I know people in NCISH are going to absolutely try their best to keep answering them on Twitter, probably over the next few days, because there's been so many of them. So you've made my job difficult, which is brilliant. So I'm just going to try and pick a few out and we can discuss kind of some of the main things that seem to be coming out. But apologies if I don't get to your question. But Jenny, I thought perhaps we could start with you, because there's been a question just around understanding whether, when Lewis talked about drug and alcohol misuse as one of those risk factors, whether that's about illegal substance misuse and or misuse of legal and prescribed substances. So it'd be great to just get a bit of clarity on that. And then perhaps there's another question about what research is actually going on around drug misuse as a social issue, so not just a mental health issue. It'd be great if you could start us off.
Okay, so the data that Lewis described was on patients in mental health services, and the substances are most commonly of misuse are opiates. That always comes out as the most common substance of misuse leading on to suicide. I suppose just a little bit about the study that we're about. You know, the differences of looking at substance misuse in mental health patients. What we're looking at is much broader than that. It's looking at people who've had contact with drug and alcohol services, many of which are not run by the NHS. So we want to explore, which hasn't been done before, to look at suicide, the prevalence of it in people who are in contact with those services in the last year, but also the characteristics of people who die by suicide, who are in contact with those services. And that will provide us with much more information in the area you're asking about, Jackie, about what are the substances that they're using in greater numbers, and what is the pattern of their characteristics and presentation to services. And also, very importantly, which is an area we've tried to look at from the mental health side, is the links between mental health services and drug and alcohol services, which we know are problematic, and quite often there's a great deal of silo working. So I think we'll be able to explore that as well in a bit more detail, as well as the substances of use. So I think that will enlighten us a great deal. So in terms of your broader question about broader research on substance misuse, I suppose my area is more to do with substance misuse in the criminal justice system, and within that setting there's been a great interest in the use of spice and other such substances, which have led to have been associated and linked to an increasing number of suicide within the criminal justice system, particularly prisons. So that's an area of great concern within that setting. There are moves afoot to try and sort of help that problem within that setting.
Thank you, that's really helpful, and we'll be looking forward then to next year and the year after's report to hear some of that research, if those findings come out. That's really, really important. And maybe it sort of takes us on to that place, thinking about within communities the different role that different kind of bits of the system have as well, and thinking about physical illness. So Lewis, you talked about the physical illness risk around suicide risk as well. And I was just thinking about the GP's role in that. So a few people have talked about GPs and primary care, which we haven't actually touched on very much during presentations today. And I didn't know whether you wanted to say something about the role of GPs and primary care in relation to suicide.
I guess in a nutshell, it's a really important role. So if you look at what service do people contact the most? So we very much focus on emergency departments, but actually, if you're thinking about numbers, more people are in contact with primary care. However, for GPs, it's really difficult amongst all the people they see to identify those most at risk. And I guess so I saw that Isabel Hunt put a question in the chat about, are GP information systems good enough for managing this issue? And I think in some ways, yes, they are, but it's difficult to identify these things. So one of the things, if you look back in someone's history, the things we identify, like a history of, going to the emergency department with substance misuse, recent relationship breakdowns, in fact, all the pieces of work, even the ones we did during COVID, many of the risk factors are ones that we know about. And I guess there's something about those in primary care and across all other services, understanding those risk factors in someone's past history, and then having the resources, and by that I mean time and training, to be able to ask the right questions when people come in front of them. And a lot of that is about the relationships that people have with their GPs. Like, one of the things that I really remember from some work we did was that a young person from quite a deprived background with lots of substance misuse problems, basically saying that he thought his GP was too posh to talk to this stuff about. So there are basically, there's ways we need to open up those conversations in services.
Yeah, Jackie, I might just come in there. So I think that's like spot on, because one of the things is GPs saying, well, can we, how can we spot who's at risk? And the answer is you can't. So it's about providing better care for everyone that comes through kind of primary care. Obviously, that's a major challenge. And so it's about better systems of care. So it's about not just primary care, it's about how you link to secondary care services, how you link to IAPT, how you link to all the services services around you. And the third thing I think is really important that Anne's highlighted is the role of education. So GPs do lots. Obviously, they're not going to become experts in all things to everyone, but it's about having those kind of basic skills and how we best get those skills out to people. So we work with kind of a lot of areas across the country as part of this kind of quality improvement program, and a lot of areas are kind of grappling with this and doing kind of excellent work with their local GPs.
Thanks, Nav. And does that take us on to this question around risk a bit more as well? So there's been a couple of questions around, well, one question is, why is it so difficult to implement uniformity in risk screening? But I think there's a wider question there, right, about risk assessments, what sort of conversations should be had? Maybe you could talk to us a bit about that.
I can. I'm sure everyone will want to chip in on this one. I mean, the basic problem is that I think we've had risk all wrong for about the past kind of 30 years or so, in that we've talked about it in terms of kind of predicting who's at risk or not, and really that's what it shouldn't be about. That it should be identifying, you know, factors that are pertinent to the individual, particularly factors that, you know, we can do something about, so modifiable factors, individualized assessments, and not just the assessments. We should be thinking about kind of management. So I think we've talked previously, all of us, about moving away from risk as prediction, and thinking about, you know, the assessment, thinking about management. The universality kind of argument is a really interesting one, and it's an argument used by some people for why we need risk assessment tools, because practice is so varied. So if we had tools, everyone would do the same thing, you know, it would be fine. In fact, when we surveyed this, we found in the 60-odd mental health trusts, there were 150-odd different risk tools being used, and in many cases, they were just risk tools that people had kind of made up themselves. So uniformity is a real problem. For me, though, it isn't about having a uniform tool. It's about agreeing what the kind of key factors are. And I don't think actually it's that difficult to kind of decide. So suicide bereavement, I think, was mentioned in the chat. Another one that comes up is, you know, assessing young people's use of the internet and social media. You know, these are things that we could incorporate into assessments. I think it's unhelpful if we have a big long list of questions that people will ask, because that detracts from the clinical nature of the assessment. But it isn't too difficult in NICE guidelines, in clinical competency frameworks, to have a kind of core set of things that we agree on. The challenge then is implementing them, getting them out to the front line, making sure staff have the training and the time to implement them. That's a whole other story.
But a frustrating story, right? For people who feel they've been saying this stuff for a while, but how do we get that change to happen then? And Lewis or Nav, either of you, I don't know if you want to comment on how do we really create that change? I think
Anne wants to come in as well, but Lewis, I think, for implementation.
Well, first of all, the model of risk, which you can see how these things evolve. In trying to understand risk, we want the whole of suicide prevention has been, for many years, has been trying to spot common risk factors. So, what are the things that we might base that estimation of risk on, and that might apply in any setting. And I think we're into a new phase now. Even though that was helpful, so most people know some of the main risk factors for suicide, whether it's substance misuse or isolation, and so on, and mental illness, especially depression. So those risk factors have been identified, but what the phase we need to get into is the more personalized understanding of what puts a person at risk. So an individual can have a number of risk factors, but another individual might have only one key risk factor, but for that person, it is so profoundly unsettling that it puts their life at risk. And having a service that's built around that personalized understanding is where we need to get to. And so the message of our report today, but it's not just today, it's been in there for a while, is that we need to see that if you look at a different group, whether it's people under 18 or people who are economically stressed, then you will see a different grouping of risks. And our job is to understand how they play out in the lives of individuals. And the problem of risk assessment tools is that they are generic. They don't allow that kind of personalized approach. The problem of risk assessment generally, whether it's tools or simply clinical assessment, is it tends to be a snapshot. So it doesn't allow for the dynamic nature of risk. Things happen to people. People's lives are complex. They can feel all right one day, and then the next day things go wrong and they can be back at risk. And so our model has to be sufficiently, it's not about predicting, it's about understanding the personal nature of what puts people in distress and at risk. And that's where we need to be able to get to. Doesn't mean we're not any good at risk assessment, by the way, although we should give up the concept of risk and safety. It's about how we do it, about how we understand it, how we understand people.
And did you want to come in on that?
There's only a couple of things I wanted to add. So I think that the issue around risk is dynamic is really important to get across. And I think some of the tension around risk assessment, because I think sometimes you could look at all the evidence and think, why are services still using these things? And it's because for lots of people who were asking to make assessments, they're not very specifically trained. They're not entirely comfortable asking the questions that we want them to ask. And they can't always remember what those risk factors are. So I'm talking about, you know, people who are generally trained in emergency departments or prison guards or people working in citizens advice bureaus. And so risk assessment is almost like a security blanket, isn't it? It tells you what to do and it gives you an answer. And so I think it's through that understanding of why they're used so widely that we can address the gradual removal of them being used in that way, because it is a very, as Lewis Adnab said, a very personal assessment of someone's risk. But even if you assess it in that moment, it might be different an hour later. You know, so I always struggle with when people in inpatients are assessed as low risk. You know, how can they ever be low risk? They're inpatients in mental health units. So I really think it's understanding why people use them and then giving people the tools that within the limits of what they're doing in their own training, that they feel comfortable in knowing how to make, you know, some of those some of those conversations, address what they can, and then signpost on.
I think it's worth saying that when services, I mean, Anna's absolutely right. When services are under a lot of pressure, when they're not sure where they're going to seek the support that they need for the patient who's in front of them, then they're going to be less inclined to identify the risk. So if there's one, throughout the whole of the health service, if there's one thing that puts you off finding a problem, it's that you might not know what to do about it. And so so risk assessment, fine. We have a discussion about risk assessment, very important. Let's get rid of risk assessment tools. Let's not give up on risk assessment, but let's get rid of risk assessment tools. And but doing that without creating the service to support the judgments is only half the story. And when we talk about GPs, for example, you know, that's what GPs will tell you. Ask GPs, they don't say, you know, I wish I could go to more training courses. What they say is, I wish you would provide the services that would allow me to refer the patients who I identify as needing further care. And it's creating the care pathways, if you like. It's creating the next step for people who need more. And when we assess risk, what are we really doing? Nav is right, we're not predicting. We're trying to make a judgment about the proportionate response, the comprehensive response to what people are telling us. It's a very pragmatic process. What can we help you with that would make you safer? And to do that, we need to have the services that would support, not just in mental health care, social care, maybe the justice system, physical health care, and the voluntary sector.
So what about then? There's lots of different groups of people at risk, lots of, you know, different risk factors, and services absolutely critical to that. Someone in the chat has mentioned the Gypsy, Roma and Traveller community, for example, thinking about all the stuff that Nav presented. How do we get targeted, culturally appropriate responses for people as well? I don't know who wants to take that. Nav, do you want to take that?
Yeah, I can do. I think it begins with research, so it begins with understanding the problem, but that shouldn't be used as an excuse for not doing stuff. And for me, you know, drawing on our own research, that study of self-harm that Bushra led that I presented, there were two things about that study. The first thing is about, well, is it is the lack of access to mental health services because people aren't coming forward? In which case, what you're doing there is a kind of awareness raising, kind of, making sure people know that the services are there. Troublingly, that didn't seem to be the only thing. So, troublingly, there were suggestions in the data that services weren't really fit for purpose. So, when people did present from an ethnic minority, they were less likely to re-present. So, there's something there then about making services fit for purpose, making services kind of culturally appropriate. And then the third thing I think that was troubling, the third aspect of it, and the third strategy you might use is thinking about our staff. Because I think the two findings that troubled me a little bit were first the risk finding. So people from an ethnic minority group who died by suicide had a lower rating of risk. So the risk was underestimated in that group compared with the white population. And the other thing was about less likely to get a psychosocial assessment after self-harm. People from an ethnic minority. So there, if you like, the gatekeeping is in the staff. So we need to be thinking about why staff might be less likely to be referring those people. So there's probably a kind of staff training issue. There's a developing, if you like, culturally adapted interventions issue, and then there's a whole access issue. So they're the three things I think we would need to tackle.
Thank you. Not easy things to tackle though, right? They're big, some of these are big thorny issues, aren't they, as well? So another big thorny issue, economic recession, adversity. Again, we know rates went up, kind of 2000, rates went up after the last recession. Lewis, you flagged in the work that you did around concerns around economic adversity and people experiencing that. What are the lessons we can learn from kind of what happened last time, and what can we do now to try and sort of get ahead of the game if we can?
Well, I think you're right to refer to the 2008 recession. I mean, it's a general rule that most major economic downturns throughout recent history and wherever you are in the world have had an impact on mental health, and most have gone on to have an impact on suicide. So it's a very important period that we're entering, where people got very worried about the pandemic, but we're entering a period where history tells us suicide rates tend to go up. That the economic news for many people is very bleak at the moment. If we take the 2008 model, because it's fairly well researched, 2008 recession, a couple of important things. A number of countries saw a rise in suicide rates, but they didn't always all see a rise to the same extent. And that tells us that there are mitigating interventions that we need to take. And they tend to be around supporting people who are economically vulnerable through employment support and welfare support, the big issues that affect people's lives and their security. I think the second thing it told us was that the effect is not immediate, or at least it's not just immediate. There can be an immediate effect, but that the peak rise in suicide rates. So I don't know if everybody remembers, but in 2006-07 we had the lowest suicide rate we'd ever had in England, and then the rate started rising after the 2008 recession. But it didn't reach a peak until around 2012-13. So the effect is long term, and it's not enough to put in place short-term economic supports. They have to be longer term, because people's economic difficulties escalate and they enter a vicious circle. So there may be job insecurity, but then people start borrowing money, they end up in debt, they fall into mortgage arrears and their house or rent arrears, and their housing security is undermined, and so on. So they go from one economic stress to another, and our supports have to be flexible enough to track the main areas of economic distress.
And just to add, just a couple of things. So completely agree with everything Lewis said. If you look at that recession, suicide rates started rising slightly before unemployment rates. So that whole period of transition and uncertainty it's really important we act quickly, I think, when we know we're entering these sorts of periods, which are, I think we're sort of in at the moment. And active job labour markets the countries that employed, you know, whereas we went for, oh God, I've forgotten the term we used.
Austerity.
Austerity. While we went for austerity, other countries had different approaches, and that did seem to work. And then I think, you know, in Wales, we're trialing things like universal basic income. And, you know, and I think there are real innovative ways that we can address adversity for the most vulnerable people in our society at a population level that we really need to be advocating for.
Yeah, and there's stuff from the international literature, you know, from Brazil, you know, actually making direct payments to people and the association with suicidal behaviour. You know, there's a whole thing about alcohol pricing. It's come up a lot in the chat. You know, alcohol pricing. You know, during a recession, what are the impacts of alcohol policies during that? So there's lots that could be done, but we do need to act quickly.
And we have an opportunity, of course, to feed in some of this thoughts around how we might want to act quickly. Lewis, I don't know whether you just want to say something about the consultation at the moment that's open around the national strategy.
Yes, so we've had a national suicide prevention strategy for 20 years. 10 years ago, it was revised. One of the big changes was support for bereaved families. And now, so 10 years on, we've reached another point of revisions. The government announced it will review and publish anew the suicide prevention plan, probably later this year. And at the moment, there's a consultation, one of those formal consultations that's online, where you can submit comments. It's partly about the mental health plan, but it's also about the separate but related suicide prevention plan. And you can let people know your ideas. If they're about suicide prevention, they get fed through to the suicide prevention team within the Department of Health and Social Care. So it's a real opportunity now to reset our priorities, things that weren't thought about maybe so much 10 years ago. I talked about domestic violence. I think that's one of the areas that we would expect to do more on. But the economic need is very pressing as well. And I think as we emerge from COVID, at least up to a point, we have to learn about the supports that could be put in place for people who might be economically vulnerable. It was a remarkable period when the economic protections were put in place in the early pandemic, but we will need something similar if we're to protect people from or equivalent at least, if we're to protect people from the worst economic news that we're facing at the moment. In some cases, the worst for 30, 40 years. So we just have to see the magnitude of the risk that this presents to people, but the remedial nature of much of that risk if we act in the right way. So the plan is a big opportunity. Jackie, you're absolutely right. If we can get some of these big issues addressed in the suicide prevention plan, then there's a very big potential payoff for the NHS and for wider society.
There you go. So a good plug. Everybody go and perhaps someone could put a link in the chat actually to the consultation because it is open at the moment.
I should say that's not the only opportunity. There will be other chances to express where you think the priorities lie. Yeah,
so also if you don't already, follow Lewis on Twitter because I'm sure he will share them on there as well. Thank you. Jenny, knowledge is all important, right, on this stuff. We've heard a lot of knowledge today. It's really critical that we learn from that knowledge. There's been another question specifically around research around specific male demographics. So there's been a lot around middle-aged men, but what about other groups of men and their interaction with services? Do we know very much about that? Male students, young men, men in prison? Is there much knowledge around about that?
I suppose as my area of expertise tends to be within the criminal justice system, we probably don't know enough about that and about the different groups. I mean, we know in general that there's a high prevalence of mental health problems in prison. The rates of suicide and self-harm are very high, as they are on release from prison back into the community. We know a little bit about the characteristics of people and problems with health seeking. I mean, in general terms, there's more chaotic help seeking prior to coming into the criminal justice system, more reactive care, sort of presenting to A&E in crisis, rather than sticking to more consistent models of care. And so in prison health, it's an opportunity to try and mend some of that and to try and engage with people who are in the criminal justice system to help them to engage with services when they leave. And so this is some of the work that we've been trying to do to help this group of people who, of course, are in prison for a short length of time and then back in the community. So if we could encourage them in their engagement with services whilst in that system, then hopefully that will help them to kind of present in a different way in the future. And there are other groups who are similar, like homeless people and other groups that present in that more chaotic, reactive way, that, you know, there are models to try and work with some of that to sort of improve engagement. And similarly, we're beginning to work in the criminal justice system to look at people from minority ethnic backgrounds within that system and their issues in relating to services, and trying to work with that in the criminal justice system to try and improve that when they transition back out again.
I think it's fair to say in terms of the kind of research, but there's lots around there about descriptive epidemiology, trying to unpick the causes. There's not a huge amount on gender or sex specific interventions, really. Even the trials that have been done, sometimes you can't separate out men and women in the trials. So there's lots more work to be done, I think.
Just to
we've got 1 minute left, Anne.
One of the things we found in a study with young people contacting services was that even with the same method of self-harm, boys were less likely to be admitted than girls. So I think, as well as help seeking, there's something about our responses to men in distress, men and boys in distress, that we should reflect on as providers.
Thank you. So there is a huge kind of amount there that you've heard today, huge amount of knowledge. Thank you to everybody that's been involved, not just our speakers that you can see on the screen now, who've been absolutely brilliant, also to the three dads, also though to everybody at NCISH who hasn't had their faces on the screen today. I'm sure Lewis would say it's absolutely a joint effort. They couldn't do this without all of you. So thank you very much indeed. I'm sorry we didn't get to all of the questions. We've done our best. We'll try and get them out on Twitter for you. And I think there's just a really key theme here, that it's using this knowledge, trying to change people's lives. That's what we're all here for. Oh, it's brilliant. Mike, thank you for popping up again. Since I can see you, I don't know whether you want to you've got like 30 seconds if you want any last reflection. Or if you can't find the unmute button, that's totally fine as well. There you go.
I found it. Yeah, absolutely wonderful. This research is absolutely vital, important, and bringing everyone together today, it can only enhance and save lives. It's as pure, as simple as that.
Wonderfully said. So with that, I'll thank everybody again, and all credit to Lewis and his team for putting on a fantastic event, and enjoy the rest of your day. Thank you all.
Thank you.
Bye, everyone.